Hello, I'm Dr. Jasmine Sukumar, your guest host of the ASCO Daily News Podcast today. I'm an assistant professor and breast medical oncologist at the University of Texas MD Anderson Cancer Center. On today's episode, we'll be exploring advances in adjuvant therapy for high-risk early breast cancer in people with BRCA1 and 2 germline mutations. Joining me for this discussion is Dr. Dionisa Quiroga, an assistant professor and breast medical oncologist at The Ohio State University Comprehensive Cancer Center. Our full disclosures are available in the transcript of this episode. Dr. Quiroga, it's great to have you on the podcast. Thanks for being here.
Thank you. Looking forward to discussing this important topic.
Let's start by going over who should be tested for BRCA1 and 2 genetic mutations. How do you identify patients with breast cancer in your clinic who should be offered BRCA1 and 2 genetic testing?
Guidelines on who to offer testing to somewhat differ between organizations at this point. I would say generally, I do follow our current ASCO Society of Surgical Oncology guidelines, though. Those guidelines recommend that BRCA1/2 mutation testing be offered to all patients who are diagnosed with breast cancer and are 65 years old or younger. For those that are older than 65 years old, there are additional factors to really take into account to decide on who to recommend testing for. Some of this has to do with personal and family history as well as ancestry. The NCCN also has their own specific guidelines for who to offer testing to. For example, people assigned male at birth, those who are found to have a second breast primary, those who are diagnosed at a young age, and those with significant family history should also be offered BRCA1/2 testing. I think very important for our discussion today, ASCO and SSO also made a very important point that all patients who may be eligible for PARP inhibitor therapy should be offered testing. So clearly, this includes a large amount of our patient population. In my practice, we often refer to our cancer genetics program. We're fortunate to have many experienced genetic counselors who can complete pre-test and post-test counseling with our patients. However, in settings where this may not be accessible to patients, it can also be appropriate for oncology providers to order the testing and ideally perform some of this counseling as well.
Thank you, Dr. Quiroga. Let's next review where we are in current clinical practice guidelines. What current options do we have for adjuvant therapy specific to people with high-risk early breast cancer and BRCA1 and 2 genetic mutations?
Yeah, our current guidelines recommend adjuvant olaparib for 1 year for individuals with HER2-negative high-risk breast cancer. This approval largely came from the data and the results of the OlympiA trial. This was a prospective phase 3 double-blind randomized clinical trial. It enrolled patients who had been diagnosed with HER2-negative early-stage breast cancer who also carried germline pathogenic or likely pathogenic variants of either the BRCA1 and or BRCA2 genes. The disease also had to be considered high risk, and there were several criteria that had to be evaluated to deem whether or not these patients were high risk. For example, those who are treated with neoadjuvant chemotherapy, if they had disease that was triple negative, they needed to have some level of invasive residual disease at time of surgery. Alternatively, if the disease was hormone receptor positive, they needed to have residual disease and a calculated CPS plus EG score of 3 or higher. This scoring system is something that estimates relapse probability on the basis of clinical and pathologic stage, ER status, and histologic grade. And this will give you a score ranging from 0 to 6. In general, the higher the score, the worse the prognosis. This calculator, though, is available to the public online to allow providers to calculate this risk. For the subset of patients who received adjuvant chemotherapy, for them to qualify for the OlympiA trial, if they had triple negative disease, they needed to have a tumor of at least 2 centimeters or greater and or have positive lymph nodes for disease. For hormone receptor positive disease that was treated with adjuvant chemotherapy, they were required to have 4 or more pathologically confirmed positive lymph nodes at time of surgery. From this specified pool, patients were then randomized 1-to-1 to get either adjuvant olaparib starting at 300 milligrams twice a day or a matching placebo twice a day after they had completed surgery, chemotherapy, and radiation treatment if needed.
And what were the outcomes of this study?
The study ended up enrolling over 1,800 patients. And from these 1,800 patients, 70% had a BRCA1 mutation, while 30% had a BRCA2 mutation. About 80% of the patients had triple negative disease compared to hormone receptor positive disease. Interestingly, about half of all patients enrolled had received neoadjuvant chemotherapy, while the other half received adjuvant chemotherapy. Looking at the outcomes, this was overall a very positive study. We actually now have outcomes data from a median of about 6 years out. This was just reported in December at the 2024 San Antonio Breast Cancer Symposium. There was found to be a 9.4% absolute difference in 6-year invasive disease-free survival, favoring the olaparib arm over the placebo arm. What was also interesting is that this was consistent across multiple subgroups of patients, and the benefit was really seen whether or not they had hormone receptor positive or triple negative disease. The absolute difference in distant disease-free survival was also high at 7.8%, and additionally favored olaparib. Most importantly, there was found to be a significant overall survival benefit. The 6-year overall survival was 87.5% in the olaparib group compared to 83.2% in the placebo group. This translates to about a 4.4% difference and a relative 28% overall survival benefit in using olaparib. Now, future follow-up is going to be very important. Follow-up for this study is actually planned to continue out until June 2029. So we can continue to observe if these survival curves will continue to branch apart as they have so far at each follow-up. And I think this is especially important for those patients diagnosed with hormone receptor positive cancers, because we know those patients are at particular risk for later recurrences. As an additional side note, the researchers also noted that there were fewer primary malignancies in the olaparib group, not just of the breast, but also primary ovarian or fallopian tube cancers as well, which is not completely surprising, knowing that this drug is also heavily used and beneficial in different types of gynecologic cancers. Ultimately, the amount of adverse events reported have been low, with only about 9.9% of patients receiving olaparib needing to discontinue drug due to adverse events. And this is compared to 4.2% reported in the placebo group.
You mentioned that the OlympiA trial showed an overall survival benefit, but interestingly, the OlympiA trial, looking at olaparib versus chemotherapy in patients with advanced metastatic HER2-negative breast cancer, did not show a significant overall survival benefit. Could you discuss those differences?
I agree. That's a very good point. So OlympiA's comparator arm was, of course, a placebo. So while this isn't the same as comparing to chemotherapy, it does still potentially suggest that there is a degree of benefit that olaparib can provide when it's introduced in the early local disease setting compared to advanced metastatic disease. I think we need more future trials looking at potential other combinations to see if we can improve the efficacy of PARP inhibitors in the metastatic setting.
For patients who do choose to proceed with use of adjuvant olaparib due to the promising efficacy, what side effects should oncologists counsel their patients about?
The most common notable side effects, I would say, with olaparib and other PARP inhibitors are really cytopenias. Gastrointestinal side effects such as nausea and vomiting can occur, as well as fatigue. There are some less common but potentially more serious side effects that we should counsel our patients on. This includes pneumonitis, so counseling patients on if they're short of breath or experiencing cough to let their provider know. Venous thromboembolism can also be increased rates of occurrence. And then, of course, myelodysplastic syndromes or acute myeloid leukemias is something that we often are concerned about. That being said, I think it should be noted that interestingly, in the OlympiA trial so far, there have been less new cases of MDS and AML in the olaparib group than actually what's been reported in the placebo group at this median follow-up of over 6 years out. So we'll need to continue to monitor this endpoint over time, but I do think this provides some reassurance.
Since the initiation of the OlympiA trial, other adjuvant treatments have also been studied and FDA approved for non-metastatic HER2-negative breast cancer. So, for example, the CREATE-X trial established adjuvant capecitabine as an FDA-approved treatment option in patients with triple-negative breast cancer who had residual disease following neoadjuvant chemotherapy. So, if a patient with triple-negative breast cancer with residual disease is eligible for both adjuvant olaparib and adjuvant capecitabine treatments, how do you decide amongst the two?
If a patient's eligible for both, I honestly often favor olaparib. And I do this because I find the data for adjuvant olaparib a little bit more compelling. There's also differences in toxicity profile and treatment duration between the two that I think we should discuss with patients. For example, olaparib is supposed to be taken for a year total, whereas with capecitabine, we typically treat for 6 to 8 cycles, with each cycle taking 3 weeks. There are some who may also sequence the two drugs in very high-risk disease. However, this is very much a data-free zone. We don't have any current clinical trials really comparing these two or if sequencing of these agents is appropriate. So I don't currently do this in my own clinical practice.
Nowadays, almost all patients with stage 2 to 3 triple-negative breast cancer will be offered neoadjuvant chemotherapy plus immune checkpoint inhibitor therapy pembrolizumab per our Keynote 522 trial data. With our current approach, pembrolizumab is continued into the adjuvant setting, regardless of surgical outcome, so that patients receive a year total of immunotherapy. So in patients with residual disease and a BRCA germline mutation, do you suggest using adjuvant olaparib concurrently with pembrolizumab? Do we have any data to support that approach?
I do. I do use them concurrently. If a patient is eligible for adjuvant olaparib, I would use it the same way as if they were not on pembrolizumab. That being said, there are no large studies currently that have shown what the benefit or the toxicity of pembrolizumab plus olaparib are for early stage disease. However, we do have some safety data of this combinatorial approach from other studies. For example, the phase 2-3 KeyLink 009 study showed that patients with advanced metastatic triple-negative breast cancer who were receiving concurrent pembrolizumab and olaparib had a manageable safety profile, particularly as the toxicities of these drugs alone don't tend to overlap.
And what about endocrine therapy for those that also had hormone receptor positive disease?
Adjuvant endocrine therapy should definitely be continued while patients are on olaparib if they're hormone receptor positive. An important component of this will also likely be ovarian suppression, which should include recommendation of risk-reducing bilateral salpingo-oophorectomy due to the risk of ovarian cancer development in patients who carry BRCA1/2 gene mutations. In most cases, this should happen at age 40 or before for those that carry a BRCA1 mutation, and at age 45 or prior for those with BRCA2 mutations.
And do you also consider adjuvant bisphosphonates in this context?
Yes, like adjuvant endocrine therapy, adjuvant bisphosphonates were also instructed to be given according to standard guidelines in the OlympiA trial. So I would recommend use of bisphosphonates when indicated. You can refer to the ASCO Ontario Health Guidelines on adjuvant bone modifying therapy breast cancer to guide that decision in order to utilize this due to multiple clinical benefits. It doesn't just help in terms of adjuvant breast cancer treatment, but also reduction of fracture rate and down the line, improved breast cancer mortality.
Particularly in hormone receptor positive breast cancer, another adjuvant therapy option that was not available when the OlympiA trial started are the CDK4/6 inhibitors, ribociclib and abemaciclib, based on the NATALEE and monarchE studies. So how do you consider the use of these adjuvant therapy drugs in the context of olaparib and BRCA mutations?
Yeah, so we are definitely in a data-free zone here. And that's in part because the NATALEE and the monarchE studies are still ongoing and reporting data out at the same time that we're getting updated OlympiA data. So unlike some of our other adjuvant treatments that we discussed, where olaparib could be safely given concurrently, the risk of myelosuppression in using both a CDK4/6 inhibitor and a PARP inhibitor at the same time would be too high. In some cases, even if a patient has a BRCA1 or 2 mutation, they may not meet that specified inclusion criteria that OlympiA set for what they consider to be high-risk disease. And we know from the NATALEE and the monarchE trial, there are also different markers that they use to denote high-risk disease. So it's possible, for example, in the NATALEE trial that looks specifically at adjuvant ribociclib, they included a much larger pool of hormone receptor positive early stage breast cancers, including a subset that did not have positive axillary lymph nodes. In cases where patients would qualify for both olaparib and a CDK4/6 inhibitor, I think this is worth a nuanced discussion with our patients about the potential benefits, risks, and administration of these drugs. I think another point to bring up is the costs associated with these drugs and the length of time patients will be on for, because financial toxicity is always something that we should bring up with patients as well. When sequencing these in high-risk disease, my practice is to generally favor olaparib first due to the overall survival data. There is also some data to support that patients with BRCA1/2 germline mutations may not respond quite as well to CDK4/6 inhibitors compared to those without. But again, this is still outside of the purview of current guidelines. Fortunately, we have more potential choices for patients, and that's a good thing. But shared decision-making also needs to be key.
And while our focus today is on adjuvant treatment for people who carry germline BRCA mutations, what about other related gene mutations, such as PALB2 pathogenic variant?
That's a great question. Clinical trials in the advanced metastatic setting have shown that there is efficacy of olaparib in the setting for PALB2 mutations. This is largely based on the TBCRC 048 phase 2 trial, and that provided a category 2B NCCN recommendation for patients with these PALB2 gene mutations. However, we're really still lacking enough clinical data for use in early stage disease, so I don't currently use adjuvant olaparib in this case. I am definitely eager for more data in this area, as the efficacy of PARP inhibitors in PALB2 gene mutations is very compelling. I think also in the same line, there's been some data for somatic BRCA1 and 2 mutations in the metastatic setting, but we still have a lack of data for the early stage setting here as well.
Thank you, Dr. Quiroga, for sharing your valuable insights with us today on the ASCO Daily News Podcast.
Thank you, Dr. Sukumar.
And thank you to our listeners for your time today. You'll find links to the studies discussed today in the transcript of this episode. Finally, if you value the insights that you hear on the ASCO Daily News Podcast, please take a moment to rate, review, and subscribe wherever you get your podcasts. Thank you.
The purpose of this podcast is to educate and to inform. This is not a substitute for professional medical care and is not intended for use in the diagnosis or treatment of individual conditions. Guests on this podcast express their own opinions, experience, and conclusions. Guest statements on the podcast do not express the opinions of ASCO. The mention of any product, service, organization, activity, or therapy should not be construed as an ASCO endorsement.